Okay, I'm Claire Ronalds. I work for the Chartered Society of Physiotherapy, supporting our members in Northern Ireland. Next to me is Janet Fletcher, who works for the Society of Radiographers, and Kevin Cadam, who works for UNITE, the union. Hopefully you've received, we did put in a written submission to hopefully sort of make things a little bit smoother today. Really what we were wanting to present to you was just the evidence from some of the staff groups that I think tend to get a little bit forgotten in A&E because they're not seen as being right on the front line. And that would be for myself, the physiotherapists that we support, the radiographers and also the pharmacists, who are all integral to the smooth running of an A&E service, but often not seen as being on that front line. So we did include for you a few of the issues staff had raised with us around about the physical conditions, and a little bit about waiting times and triage, and then much more around about our recommendations for where some improvements could potentially occur.
Do you want to say some of that, or do you want us to kind of...
I mean, if you want me to read through the statement, but I was sort of hoping that I don't want to take up your time on that. I'm kind of conscious that we're in a kind of public arena, so others in the audience won't have the statement before them, so it might be worth quickly running through that, yeah. For us, I mean, radiography and pharmacy would tend to be within their own departments rather than directly in an A&E unit. But for radiography, this can actually be a problem, as sometimes the flow of the patients coming out of A&E isn't always thought about as A&E departments are redesigned. So as you get more patients coming into A&E, you need to have the space for them coming into X-ray as well. So you can get physical bottlenecks for patients where there's insufficient waiting areas in X-ray and a difficulty in physically getting patients in and out of the department. It also has to be remembered that patients have to be repositioned quite often to get their X-ray or their scan, and you need the right number of staff to be able to physically manage that. And as you move into out-of-hours service, those staff numbers can change. Also, when a patient goes to X-ray, they need to be able to go back to the A&E department afterwards, so you need to have that ability to hold the bed so that patients aren't then sitting waiting for another space again. So some of the problems that's created that members have raised with us is sick patients being left in X-ray waiting areas unsupervised because they can't get back into A&E, or patients waiting on ambulance stretchers as there's no trolleys for them, which means that the ambulances then can't get back out. Being outside of the main department can also cause problems for pharmacy because they are sort of dealing with the tail end of things. And if your A&E staff have quite a quick turnover or changes in staffing, they may not have the medicines training that they need, so you get more problems feeding in and out. Or if prescriptions go into the wrong system, so if they go into the routine system rather than the A&E system, it can lead to a delay that is seen to be the pharmacist's fault, but is actually a fault of the system. Physiotherapy for itself is either situated within A&E, or quite often what we have is staff in the minor injuries unit or in the medical admissions unit who take calls and come in and out of A&E. The largest problem reported to me from physios is the time it can take to find a cubicle that has an adjustable bed. The trolleys that patients are on in A&E are not inadequate or too high to do a physiotherapy assessment. And also, if you're looking at somebody's mobility, if you've got an elderly patient, trying to get them off of a high A&E trolley to assess their mobility and then getting them back onto that A&E trolley. So you might have a situation where your assessment should take half an hour, 45 minutes, but it can take double that because you're having to find a space, locate a space, get the patient round to the space. The other thing for physios is that quite often with mobility problems, they're having to assess patients on stairs before they're safe to go home. Very few A&E departments are situated near stairs. So you've then got to, again, transport the patient round to the stairs. You've got to have a quiet set of stairs. You don't want to be in the middle of a main hospital trying to take somebody on stairs with walking aids so they're already anxious and you're trying to talk them through what they're doing. And some of the physios did say that if you're using some of those back stairs, as soon as you get to lunchtime, you've got trolleys that create an additional obstacle. So just where the lunch trolleys go to means that you've got an additional thing to try and get past. With waiting times, really the issue for us is that the problem with imaging and the fact that patients can be triaged and what they're requiring is imaging, and then they're waiting for somebody who has the right skills to be able to refer them on to imaging. So these patients can be more minor, but are often sitting behind the more urgent cases.
so they have an extended wait. And if you actually looked at extending roles for nurses, physios and radiographers, instead of just assuming the answer is more doctors, then these patients could have a smoother journey. Once they've been triaged, they could get referred to the right person who could then send them on for their imaging. And each of these staff groups has the basic skills that could be enhanced by training them to allow them to take on those roles. And that would leave medics free to do the more complex cases, so freeing up and using your skills resources. So emergency departments really need to analyse the type of cases that are coming in to work out how best to skill mix so that you get the right professionals in the right place at the right time. So for example, a patient with a suspected hip fracture could be assessed by the nurse practitioner. The radiographer imaging the patient could provide a written report, admit those with positive findings, or refer to a physio who could undertake an assessment, recommend treatment. If we bring in independent prescribing, the physios could actually start to prescribe the pain relief, so you've got that much smoother journey through. Again, the issue is just around about skill mix, more so for radiography, which tends to provide a 24/7 service, so you have to ensure that you've got the right skill mix at all times and that your Band 5 staff are getting access to supervision. And then with regard to sort of how staff report concerns, the problems for some of these staff groups are because they're outside of A&E, they report into their own head of service, and sometimes their concerns can get lost in the mix. So they might have some very good suggestions that go into their head of service in through that general manager, but it's then how it gets disseminated out to the groups that actually have the funding to then make the difference to that. And as I say, for us, that all leads into some of the key recommendations we would have for improving emergency healthcare, and a lot of that is around about workforce planning, but workforce planning that's actually based on the patient journey and not on professional groups. Because if you workforce plan in silos, so if you just workforce plan looking at how many medics do we need, your answer is always going to be more medics. How many nurses do we need? The answer is always going to be more nurses. But if you look at the patient pathway and what the patient requires on that pathway, it may not be more doctors and nurses, it may be more radiographers with additional skills, it may be better medicines training so that the route to pharmacy is smoother, or it may be your physiotherapists who are extended scope practitioners. And as I mentioned about independent prescribing, in the UK, Northern Ireland, as far as I'm aware, and I need to double check this still, but as far as I can see, still hasn't introduced legislation about independent prescribing for physios and podiatrists. And that opens up a whole host of new possibilities with independent prescribing. You can actually use physios in the community to try and keep some of your frail elderly patients at home rather than using up GP time or using up A&E time, and keeping them in a situation that's far better for them. And then just a simple suggestion is with regard to sort of patient attire and the safekeeping of personal effects. And again, that comes back to the patient journey and thinking about it as a whole. So where a patient may not require to get undressed within the emergency department, when they come to X-ray, they're often requiring to get undressed. Personal effects need to be removed. So you've got personal effects being removed and returned, all of which can lead to problems for patients. And the more pathways that patients' personal effects have to go through, the more risk there is of something getting lost and who's accountable for it. You've then got to trace through that whole journey. And again, within radiography, the problem is just often that you're lone working into the evenings or weekends, so the ability to actually get the patients properly attired. And then what we've included in the back is just some links to some evidence to prove the benefits of some of the allied health professions in A&E.
Okay, so that's great. I know Marion has a number of questions about kind of how involved you are in planning and delivering services. So I'm going to suggest that, given the things you've suggested, some of them strike me as having relatively limited resource ramifications, and some clearly do. But perhaps if I ask Marion to ask you questions first about the level of involvement in planning and delivery of services, because that seems like a very clear menu of improvements that you're suggesting.
Good afternoon. Just a couple of questions, and Les says largely around your involvement. And you've made some comments already about the skills mix, and if you always see the question in terms of doctors and nurses, the answer will be in doctors and nurses. And I'm wondering, therefore, when there's planning on delivery of care, to what degree are your AHPs?
Yeah, pharmacy is not included as one of the AHPs, but the rest of us would tend to be included into that allied health professions.
And I'm just wondering, to what extent are you involved in planning?
I would say a lesser extent, yes. Particularly with regard to skill mix. I know, for example, they have reporting radiographers in the Belfast Trust, and they have been trained for, I think, up to 10 years, and they have only just been backfilled, so that now they are actually able to provide hot reporting. As when we talk about hot reporting, we're talking about the patient comes in and they get a report to go back to their referrer straight away. So they're just beginning to start to actually backfill enough to make that effective. You know, there's a very different, and there's a lot of difference. There's a timely, people talk about timely diagnostics, but X-ray has always responded to timely provision of X-rays, but diagnostics actually involves timely reports back. You know, and I think that's where a lot has failed, that it's not effective if the patient doesn't have the report back again, and that really is where skill mix would be necessary, because there isn't enough radiologists to be able to provide that across the whole spectrum of reports that would need to be provided.
And I think for some of the other allied health professions, physio and some of the others that might come into A&E, like severe occupational therapists, or even for some of your patients that might be a speech and language therapist that they actually do require, because we're seen as external to that department, unless you're physically in there, it's going to be much harder to be involved in the workforce planning. So you're reporting through whichever directorate you're in, which is not always the same directorate that you're wanting to be able to influence. And then it's quite hard because you're asking for somebody to give up a bit of their budget where you can see a greater saving being realised, and people don't like giving up bits of budgets. So it's sort of robbing Peter and trying to argue that by robbing Peter you're doing more than saving Paul, you're doing an awful lot of extra provisions.
We've heard this morning, I don't know if you were here, about the new A&E at the Antrim Hospital. To what degree were other professional groups involved in the design? Because some of your evidence is relating to the non-availability of stairs and other facilities to do assessments, and how patients get their imaging done in a way that they're not having to have their jewellery on and off. And I'm just wondering, when the new department was being planned, how were you involved?
As far as I'm aware, physio probably wasn't consulted on. We currently have, speaking to the head of service today, and I think there's a band 6 who works in short stay but does a lot of working in and out of the emergency department, and they are going to look at a pilot, I think, in Antrim Hospital for a physio to deal with musculoskeletal and falls, but they wouldn't have been involved in looking at how the department was designed or what might have been required. I don't know if
I think the radiographers would be involved to some extent, in that there is often one X-ray room at least, or one or two X-ray rooms cohabiting with A&E. The problem often is that they forget that when radiographers work, particularly out of hours, they're not just providing their service in the A&E for A&E patients, they're providing it for the whole hospital, and therefore they need to think outside of their silo of A&E, that for radiography, often the main departments are shut down, almost at the weekends. We don't manpower every part of our department like we would in the core hours, and we kind of close down and go to A and base ourselves in A&E for all patients. So therefore you've got also ward patients who need to come down and therefore need to have places to weight, and I'm not sure that, although we may be involved in the design of the room that's allocated, whether we're really involved in the holistic service and the workflow of our patients through it, which doesn't necessarily include include just A&E.
And my final question.
Can I maybe just answer that with respect to pharmacy? I can't speak for the pharmacy management, but what I can tell you is from a pharmacy A&E perspective, they would say that the provision, particularly not just in Antrim but in all of the A&E centres, there is a pharmacist. That's the requirement, to have a pharmacist there. They say if they had a pharmacy technician that could deal with not just the complicated and the medicines coordinating role, the throughput and the role of the pharmacist would be much easier. So it's back to what Claire points out to resource and workforce planning, that if it was set up in that way, then those delays that are caused, and I think everybody has to contribute responsibility for those delays, but they could be reduced if pharmacy was changed from just a pharmacist, but a pharmacy technician in a support role that would increase the throughput from that perspective.
Thank you very much. My final question really is, in your role you would see patients who have particular needs, elderly with dementia, children. How do you think, when A&E are sending these people through to your services, to what degree do you think they've identified the particular needs of those people when they're coming to you for either physio or X-ray?
For myself, although I have a physio background, I work for the trade union side of the CSP, so I can only report on what the members I have reported back, and certainly none of them seem to indicate a problem with that. A lot of what they would be seeing would be your musculoskeletal type problems, your mobilisers, and sometimes your more acute respiratory problems. So that certainly nothing about sort of inappropriate referrals has been raised with me as a problem.
But in terms of the needs of the person being clearly identified and that being passed on to physios, or
it wasn't raised with me as a problem for them, so I can only sort of say what has been reported back to me.
I would say that this would have been an ongoing issue for radiographers, and it's to do with maybe it's kind of difficult to explain, but sometimes patients are left outside of your X-ray room, and because of obviously the X-ray procedure, you have to be locked into your room, so nobody can get in or out. So there's no real mechanisms for handovers, to the point where we have constantly issues raised about patients being left when the radiographer isn't even in the department. So there is no handover. So I would say that would be an ongoing difficulty for radiographers, that they don't get the information because they don't get a handover. As I say, because either they're dealing with a patient and they're physically locked in that room with that patient, or because they're in intensive care or in theatre or somewhere outside, and the person coming to deliver that patient doesn't necessarily realise that for that moment it's not being manned. So there is a continuing, and it's just the way we have to respond. You know, we may request a patient to come down and then be called urgently to the resuscitation room. So you have to go, you know, and that patient may arrive when you've responded to another urgent call.
From a pharmacy point of view, are there any issues?
No, I think my colleagues have answered that.
Okay, thank you very much. Thank you.
I really just have two questions. The first one follows on from Aaron's, and that is, having heard what seemed like from members some eminently sensible things that could be done, are there any examples of good practice across trusts where you feel that the voice of the practitioner, pharmacist, radiologist, or physiotherapist is actually being heard and acted upon? And if so, can you give us some examples? So I just wonder whether there is anything that where you feel that you are having traction in terms of getting feedback into the system and it making a difference?
For physio, I would probably say not an awful lot of examples of that, because at the moment a lot of our posts are still non-recurring funding as well. So even trying to get that security for the staff who are in post, and especially when you're getting into tighter financial times, to have your post to be on non-recurring funding becomes much more precarious. So it's really hard to feel that they're even taking the post seriously within the department.
I would, not necessarily from within Northern Ireland, although it has been, we have presented the evidence, but there is some work, and it's about changing people's care pathways. So one of the things that we quite commonly see is the elderly with potential fractured hip. In the normal process, the patient would come in, be triaged, be seen by a medic, be referred to X-ray. The radiographers in general would highlight that whether there was or wasn't a fracture through what was traditionally called the red dot system. You would put a dot on a film to say, and then they would go back to A&E. The medic would assess the patient again, see that maybe the radiographer had or hadn't red dotted it, although that was just an indication, it wasn't anything, and then decide what to do, including if it was fractured, get a consultant referral. In South Tyneside Hospital, a lady called Dorothy Keane pioneered the fact that she was a reporting radiographer. She taught all her radiographers of every grade to, a little bit more about doing a provisional report on the proviso that if a radiographer sees something and says it's fractured, it probably is fractured. Now, they may not understand what has to be done. So the care pathway for fractured hips, for example, would be 4 hours to admission from door. This lady, because of the way she taught the radiographers, the patient pathway was changed so that the patient would come in, be triaged by a nurse practitioner and referred by the nurse practitioner to X-ray. The radiographer, on seeing a positive result, would admit the patient directly to the ward. So, and then on the ward, they would have the chance at another stage to see the consultant to decide what type of surgery would be done. And they, with this new care pathway, they got 97% of their patients admitted from the door of A&E into ward within 1 hour. So it's just about looking at the whole, each care pathway, and obviously then that avoids all those interactions with the medic and then the having to wait for the consultant to come into A&E to, it was authorising other people to admit. Just on the role of reporting radiographers, they have now, the Mid Yorkshire NHS Trust has got a group, I don't know how many, I think there was about 5, what we call consultant radiographers, so reporting radiographers, and they're now providing instant reports for all A&E and GP patients to 10 o'clock, 9 o'clock, 10 o'clock at night, which is the bulk of the work. So again, the report gets back so people can get the right treatment without waiting for a decision to be made.
Okay, and on pharmacy, any?
There's a number of points and a number of initiatives over the last few years, which is ward pharmacy and ward pharmacy staff, where on larger wards there may be a pharmacist and a pharmacy technician. And all of that, this problem, as I see it from an A&E perspective, is not just about A&E, it's about releasing and having effective discharge in all the other wards. So what is being rolled out over a number of years, but still not in every ward, again it's a resource issue, is the provision of pharmacists on the ward and pharmacy technicians to manage the medicines reconciliation and to make sure patients get not just the medicine they're prescribed, but medicine they're prescribed with respect to their current medication. So it's a bigger question than just issuing a prescription. It's about issuing the right one. And again, with the increasing elderly population, the complex needs, all of those are increasingly difficult. So this is in a response to that, but it's not and hasn't been rolled out across the piece. So the answer is sitting there, but still waiting to be resourced. Another issue, I also represent laboratory staff in the pathology departments. There were designs in a number of A&E units to introduce hot labs, where the blood would, rather than being transported, would be analysed there and then. And again, that's a resource issue that has been stopped. There are designs, as I understand it, of builds or conversion of parts of A&E to facilitate that, yet it's a resource issue. So there are lots of good ways and good thinking that would speed up the problems. But again, as I see it, the resources put into firefighting, and I highlighted in the paper that we give, one of the issues is your answer is doctors and nurses, but if the doctors and nurses are not familiar, then our pharmacists are saying to us, we spend more time trying to help them and train them in medicine's reconciliation, while the real work that we ought to be doing is backing up. So while throwing more people at it might seem the right answer, it's having a negative impact.
Sure. Okay. My second question, which is one that we've asked now on a number of occasions, and that's about the question of how staff are treated. And in your representational role, is the issue of bullying a significant issue for you? And if it is it one that applies across hospitals, or is it specific trusts? Can you give me a sense of whether that's an issue or not for you in your work with members?
For physiotherapy, it hasn't been raised as a problem, and I think part of that might be that a lot of our staff in A&E would tend to be a band 6 or band 7, so they are quite experienced, and I think quite used to standing up to other people and sort of saying, no, that's not appropriate, no, I'm not going to do it. So what could be perceived as bullying, I think they have the educational skills and the experience in their role to know what is and isn't appropriate to take on. So it's certainly not been something that's come back to me as an issue for physio. I don't know about the others.
Okay.
I wouldn't say bullying in itself, but pressure to provide the services is different from just the whole pressure on. With radiography, you're responding, as I say, particularly out of hours, to the whole hospital. And everybody's wanting a piece of you at the same time sometimes. But I wouldn't say that's just to do with capacity rather than there's not being specific. That's the pressure of capacity. And just in general, the pressure, a lot of our out-of-hours work is not manned on within the contracted hours. It's done as additional hours. So the pressure to keep giving more and more and more because the shifts need to be covered, but there isn't the workforce covering. There's only one trust which has put the workforce in to cover the 7 days within contracted hours. All the other trusts work the weekends as an overtime arrangement or an on-call arrangement, whichever you want to call it. So there's a lot of pressure on getting the shifts covered.
Okay.
I'm not sure I would describe it as bullying either, but what we do experience is pressures being moved from one, as the treatment moves on. So when a nurse needs prescriptions, they do, and we do have some experience of people saying and calling it bullying, but what it is I need this script and I need it now, and this is how I need to get this patient out. And they've no time for saying, well, hold on, there's a queue here and all of these other problems. So I think there's an intolerance which leads to pressures and perceptions of bullying, and it's all symptomatic of the pressures generally in a busy A&E department.
Okay, thank you. That's really helpful. Paul.
Thank you very much for your remarks. A human rights-based approach to health sets much store by governance, by good health governance. And health governance has a number of elements, transparency in decision-making, accountability, and as much participation as possible. And participation by health professionals, participation by patients and their families, and participation by the public, working on the basis that a healthcare system is a public institution, serving the community and belonging to the community. So I wondered whether you had any brief reflections on whether it would be helpful to try and deepen the public participation. Let's focus on that bit of participation. Whether it would be helpful to deepen the public participation in the governance of the health system, including, of course, emergency care. Or do you think that the public participation in the health system is quite well catered for already through trade union representation, through 10,000 Voices, through the PCC, through patient users groups? So it's a large question, but just brief answers if you don't mind, because we're almost out of time. I'd be, to try and make it very succinct, I'd be interested to know whether you think we should be thinking about deepening public participation in the health system, including in relation to emergency care.
I think one of the first things I would say is it's not just about public participation, but public education. And I think the PCC and others have a responsibility to start and educate the public about the limitations of the health service. There is a health service out there that works and works very, very well. It is staffed by very, very good staff, but there are limitations, and not everything can be provided in the place that people think. If I translate that, A&E is not the answer for everything. It's not the front door of hospitals. And I think there's not enough done to educate the public that that's the place. There are other places, and there are other GP and out of hours and other systems that I don't think we do enough to work with the public about their use and how they can effectively reduce the need for A&E.
For me, again, I think it's more to do with the education of the public, and sometimes the education into the roles that allied health professions hold. Because anecdotally, what you often hear is patients will get the right service at the right time, often with an AHP rather than a medic, and then you'll get the question of, but when do I see the doctor? So they don't think their treatment's been complete because they haven't seen who they expected to see. So I think as health develops and evolves, we need to be able to communicate who are going to be the right people to see you and what your pathway might be within that journey, or even that pathway may take you completely away from A&E and into a service that keeps you within the community.
Yeah, I don't think I've got much more to add. I agree with Kevin that the public perception of what should be delivered in ED is often not, and I know that's seen within my profession, that you're x-raying people in the middle of the night that really are not either an accident or an emergency in any way, and they should be seen through a different pathway. But should they be involved? Well, yes, they should be involved, but we need to look at educating them into the changing care pathways.
Okay, thanks.
Do you want to make any final comments or anything you think we've not covered before finishing? Any one of the three of you?
Probably for me, it's just that there's one example that I didn't manage to include in the paper because one of my colleagues has just come back to work. It's around about looking across at other systems and what they're doing. And in Portsmouth, we've got evidence of 3 health trusts working together to ease the pressure on a casualty department. And what they did was a physio-led community assessment lounge, which was set up in December 2012, open 7 days a week from 9 a.m. to 9 p.m. And patients who are 65 or over who go to A&E are taken to the lounge first, so they kind of go there almost for their triage, and that's to see if they can be treated at home rather than taking up a hospital bed. And they stay in that departure lounge almost until arrangements can be made for what requires to be set up. And between December 2012 and May 2013, they saw 1,015 patients, and 584 of them were treated outside the hospital, which created a saving for the trust of 1.6 million. So again, they had to invest in this service, but the savings they realised from it. So if you can put that short-term investment into alternatives. And I think the big plea for us is really just that workforce planning, that it's not thinking in silos and it's not firefighting.
Okay.
Just my only comment, and it's to do with the workforce planning and just involved in the closure of the A&Es, and the difficulty within radiography of that is that, for example, when the City Hospital closed, there was 2 radiographers on site providing the service for the hospital, and there would have been 2 on site in the Royal. When the City Hospital closed the A&E, they didn't necessarily not need the 2. You couldn't just transfer it like you could have transferred the nurses, because they were providing for the whole hospital. You still have to provide some type of X-ray out of hours, and so therefore the workforce wasn't able to move with the closures, and that has created a little bit of a knock-on effect for then the ones who didn't have time to upskill or didn't have the ability to fund another person on night duties.
Okay, thank you. The written evidence you've given us has been really helpful. If you want to give us anything further, either to augment what you've said today or you think there's anything you've missed, please do so. We'd welcome additional submissions. And it just remains for me to say thank you very much for coming this afternoon. That's been really helpful to us, so thank you.
Thank you. Thank you.